So, to start off, could you explain the mechanisms by which immune checkpoint inhibitors work to modulate the immune response?
Sure. So I think the first thing to try and understand is actually how the immune system works, and then we'll have a better sense of how we kind of drug it. Whether you realize it or not, your T cells are designed to grow up, do something, and die. You don't want your T cells or your B cells sticking around too long. So there's a series of mechanisms built in to immune effector cells that allows them to stick around for the right amount of time and go away. So if you were a little kid and every time you got a virus, you had an expansion of your T cell population and your B cell population. By the time you're 3, you need a Mack truck to carry these things around. So these cells are designed to apoptose, to die off, just like losing leaves on a tree. But there's also designed to be memory left behind. Every T cell also has its own intrinsic ability to turn on and turn off. And you can think of them also as almost as like having a transmission. They can accelerate and decelerate. And that is to prevent dysregulation of the immune system. You don't want T cells amplifying and attacking things indefinitely. That's autoimmune diseases. And there's that whole laundry list of rheumatologic disorders, which are really terrible, terrible diseases. And so you have to think about how the T cells work. So the way the T cell works, when the TCR, the T cell receptor, it encounters something that it is uniquely designed to fight, you engage that synapse between the antigen presenting cell and that T cell turns on, and it turns on big time. And you want to find ways for that amplification step to not be out of proportion. And so part of the early activation of the T cell is expression of receptors that allow deactivation of the T cell response. And that's what CTLA-4 is. So early on, as the T cell amplifies, it expresses an early activation off switch so you can blunt the escalation of the immune response. So every time you get a cold, you don't get sepsis. Following that immune response is then maintained to kind of finish off whatever it is this T cell is going after. And so there's expression of the PD1 pathway, PD1 receptor, and PD2 and others. And that allows the immune response to be exhausted. So if there's a persistent immune response, you want it to stick around, but you don't want it to be infinitely sticking around. And so that's a software built into the T cell that allows exhaustion in a physiologic way. And so the physiologic use of T cells is an amplification step with autocrine and paracrine hormones like IL-2 that promote inflammation, IL-6 and others. When that is happening, the T cells turn on the brakes. They don't push the brakes, but they turn on the brakes. That's CTLA-4 for the early response. And as that response escalates, other cells in the immune system sort of push back against CTLA-4 and prevent over-escalation. And then as the immune response persists, the PD-1 pathway is there to promote exhaustion so we don't have chronic inflammation after every little infection. And those are the things that we're currently drugging. There are other drugs that are coming out against other targets and other ways of doing this, but those are the first two big ones. So you can really think about that early escalation step with CTLA-4 and that maintenance and exhaustion step with PD-1. And that's what led to these modern agents. So the CTLA-4 inhibitors, the most well-known one is ipilimumab. The other one is tremelimumab that you should be aware of. And there's emerging drugs as well. Those drugs blunt CTLA-4. They block CTLA-4. They prevent blunting of the early immune response. And the PD-1 drugs, and there's a laundry list of them, pembrolizumab, nivolumab, dostarlimab, atezolizumab, and others. Those drugs are PD-1 inhibitors or PD-L1 inhibitors, whether you're doing the ligand or the protein, sort of a nuanced distinction. And those are about preventing exhaustion of the immune response against the cancer. So in a truly, truly, truly cold cancer, if you go after it with a PD-1 inhibitor, where exhaustion is not an issue because there's no response anyway, it's not really relevant. For a cancer that is very, very visible to the immune system and the cancer fights back against the immune system by promoting T-cell exhaustion, PD-1 inhibitors are very, very effective. But also your heart and your lungs and your thyroid and your gonads and everything in your body protects itself from T cells by expressing the ligands of these receptors. So you need PD-1 so you don't develop autoimmune responses against your endothelium, your myocardium, your brain, and whatever it is. And so that's where we get into trouble with these drugs, is that we use those pathways physiologically to protect us from our T cells.